Okay, what I'd like to go over now is the impressions of Collins after doing thorough evaluation, and then also the treatment plan. So let me start with the impression sections, paragraph by paragraph, and then I can talk about each of the paragraphs once I get a chance to go through and read it. Cullen has had several clinical patterns impacting his chief complaint of poor brain function. These include unresolved attention deficit hyperactivity disorder in childhood that has progressed into adulthood, multiple traumatic brain injuries with clinical patterns consistent with microglial priming, Hashimoto's, hypothyroidism, autoimmune activity, and myelin basic protein. So we have layers and layers of stuff that is really impacting his overall brain function. Now, when you look at his attention deficit hyperactivity disorder, all that really means is they didn't have enough neuron migration, white matter development in regions associated with the frontal cortex. So we're already working with a brain that has a tendency to have reduced function and attention, focus, concentration, executive functions. And, remember in the childhood developmental disorder course, we talked about timelines of brain development. Gray matter usually develops by anywhere between age 6 to 9. White matter develops completely from ages 19 to 21. So now that Colin is his late 20s, he's that window's gone. So he's got some lack of development in that area of the brain, which makes him susceptible to dysfunction when it comes to frontal lobe aspects, and less resiliency with frontal lobe movements and activities and stressors that are involved with planning, organizing, and so forth. He's had multiple traumatic brain injuries and patterns consistent with microglial priming. So when you have head injuries where you get diagnosed with concussion and lose function, then you know that there's some activation of those microglial cells. In the neuroinflammation course, we talk about neuroglial priming. Priming is when these glial cells express into an M1 state more than an M2 state. M2 state is anti-inflammatory, M1 state is pro-inflammatory. And then trivial mechanism of inflammation can cause activation of these areas of the brain where they're primed, and then that can lead to loss of function. So for example, if he eats gluten, he's devastated and his frontal lobe function goes down because he has HLA-DQ sensitivity with gluten sensitivity, and he gets exposed to it, causes severe inflammation, and just shuts down his brain. Hashimoto's hypothyroidism. Now, Hashimoto's is autoimmunity itself to the thyroid gland. Remember, those TPM antibodies can cross-react with the cerebellum. We don't see any significant cerebellar signs, but hypothyroidism is really important because even with any kind of Hashimoto's, there's less efficiency of thyroid hormone activity, and there's the inflammatory response that impacts thyroid receptors. We went over the pathophysiology and Hashimoto's Cross Institute course in great detail, but it's just people that have Hashimoto's have inefficient synaptic activities, brain responses, plasticity. So we have that layer. And then we have myelin basic protein autoimmunity, so his immune system is also attacking the sheath of white matter that carries neurotransmission. So those are the main mechanisms that are involved with Collins' case. Then we get into the second paragraph. A careful review of his medical history and chief complaints identified that he is currently dealing with issues associated with impaired neuron endurance specific to regions of the frontal lobe. There may be associated mechanisms that are impairing normal mitochondrial function, mitochondrial biogenesis, autophagy, and insufficiency neuron energy metabolism. So, we look at his case. He's done a lot of great things for neuroinflammation. He's done a lot of great things for autoimmunity. He just keeps getting fatigued and exhausted. So this is really an endurance battle. So we really have to go after the microglia and really do all the lifestyle dietary interventions that support fuel delivery to the mitochondria. In this case, we're going to go into ketones and anti-inflammatory approach. Make sure he's got plenty of healthy blood flow, oxygenation, just to help provide the precursors for ATP. We want to have him continue taking the flavonoids he's taking, because the flavonoids he's using for neuroinflammation also impact mitochondrial biogenesis. We want to control circadian rhythm. So we really want to implement a lot of the concepts we talked about in the Crosby Institute fatigue and pain course. Okay. And then we get into, during the examination, careful evaluation for patterns associated with demyelination and cerebral cross-reactivity with TPM antibodies and myeloid protein antibodies were conducted. No patterns of motor neuron disease or examined findings were consistent with progressive demyelination. Okay. So basically, we know he's got two autoimmune target sites. One is the thyroid, and the other one is myelin basic protein. So with myelin basic protein, we know a couple things. First of all, from his case evaluation, we know he's had a recent MRI, and there is no white matter hyperintensities on his brain MRI, meaning that there's no clear pattern of demyelination, which you'd be worried about progression to things like multiple sclerosis. Now, you have to lose 60% of myelin to start showing up with high white matter hyperintensity. So, as far as we know, the autoimmune response he has are not to the point where they've caused significant destruction of his brain. Now, the next part of that is just getting to the physical examination. So with demyelination, you can have injury anywhere from the front of the brain to the back, from the top of the brain down to the brainstem. And for the most part, doing a very thorough neurological examination, we didn't see any patchy areas of demyelination in any other areas, meaning his upper brainstem, lower brainstem, middle brainstem were all intact. We didn't see any upper motor neuron signs like Trauner-Hoffmann's, Babinski, hyperreflexia, spasticity, none of the things that we associate with that. So he's got some myelin basic protein antibodies, but at this point he's done such a good job with everything. It's just neuroinflammation that's really involved with it and hasn't progressed into severe myelin destruction. Then with the thyroid, we see he's done also a very good job. He's able to have pretty consistent TSH measurements. There's a couple of little fluctuations here and there, but for the most part, he's been able to stay on the same thyroid hormone replacement and keep his TSH within normal limits. And with repeated tests of his antibodies, they don't show positive. They initially did when he was in high school, but since he's implemented his dietary lifestyle patterns, we don't see further destruction of the thyroid, causing him to constantly increase his thyroid hormones. So he's doing a fantastic job with his autoimmune disease just from the effort and time he took to learn about how to implement dietary nutrition lifestyle strategies so far. The biggest issue with Cullen is really back to the whole fatigue issue and endurance issues, and that's really going to be our clinical battle. Okay. Then I go on to say that during the physical examination, there was also notable patterns consistent with dysautonomia that may be the result of past brain injury. These examination findings include dilated pupils at rest, increased heart rate over 100 beats per minute at rest, abnormal vascular dynamics that are observable with the changes in head position and with visual inspection of the limbs. There's a 70-degree difference in temperature from the tibia to the toes bilaterally. There are no patterns consistent with cardiopulmonary disease, endocrine disease, venous deficiency, and peripheral arterial disease. So we are seeing like his sympathetic system is a little bit more active, just having dilated pupils at rest, heart rate over 100 at rest, and then autonomic changes that are impacting his blood flow. There's a 17-degree difference, and it's unrelated to anything going on with his heart or any kind of metabolic disease or venous insufficiency or peripheral arterial disease. We know that it's really the autonomics that are involved. So that may be playing a role in his inefficiency of his gut. You really can't have healthy gut function if you're constantly in a fight or flight response. So we have to see what his outcomes will be as we implement some interventions. Next, his patterns of low libido are more likely associated with lack of amygdala activity, not likely associated with hormone imbalances. Recent male hormone profiles were unequivocal. It's possible that his libido may improve if his brain endurance changes and if his symptoms are of neurogenic origin. This happens all the time. When you see a brain that's just inflamed and not active and not working well, it can impact multiple regions of the brain. If the amygdala, which is involved with sexual arousal, is just not activating, you can have libido. Hormones like testosterone activate the amygdala, but they're not the only cause of proper libido. So this is more likely of neurogenic origin. And now as his brain health improves, we want to see if his libido changes. And then I put in, Cullen has done an excellent job managing his autoimmunity with diet, nutrition, lifestyle strategies. He has not had any TPO elevation in the past few years or needs to increase his thyroid hormones due to stable TSH levels. He has done an excellent job supporting his brain function with anti-inflammatory strategies, as well as interventions to increase his brain catecholamine levels. Despite these efforts, he suffers from ongoing issues that are most likely associated with insufficient neuron energy metabolism. So basically, we got to get that neuron metabolism going. The focus on clinical management will be to optimize mitochondrial cellular deficiency, mitochondrial biogenesis, mitophagy, and autophagy in the next few months, dietary interventions, and use of exogenous ketones to promote autophagy in combination with optimizing circadian rhythm function support autophagy need to be incorporated. So we're basically shifting from the neuroinflammation course, because he's already implemented a lot of those strategies into the main concepts we talked about in the fatigue and pain course, with the emphasis on the fatigue and mitochondrial part of it. Okay. As far as lab tests, he's had plenty of lab tests. There's no additional lab tests I need from him. We don't need any additional imaging studies. We already have a brain MRI, but we definitely want to get a sleep study, see if he's got any nocturnal hypoxia patterns that are taking place. And the goals of clinical management are, 1, to modify lifestyle to avoid exceeding frontal lobe metabolic endurance. So we've got to make sure he's not constantly fatiguing his frontal lobe all day. And if he is, he's just not going to be able to recover and function. Number 2, optimize mitochondrial efficiency and dampening priming neuroglial cells with a ketogenic diet. Number 3, optimize mitophagy, achieve with consistent daily circadian rhythms and improvements in sleep. So the ability to clear mitochondria really depends on healthy sleep, and optimizing circadian rhythms can also impact that. Progress into a 3 to 5 day fast, promote autophagy and glial cell clearing. And once you get brain injury and you get patterns of like a chronic traumatic encephalopathy, and you start to have amyloid plaques built, you got to get rid of those abnormal proteins, and also the prime glial cells you gotta get rid of. And autophagy is really turned on by fasting, especially once you get past 3 days. So we got to get them into that 3 day period. So 0 to 1 to 2 days, you don't really have much autophagy. Once day 3 hits, you start to have autophagy. Then you go into day 4, day 5, you start clearing out, and you'll probably do cycles of that. Develop consistent with high ketone diet in combination with regular fasting for 6 to 8 months to determine the potential for recovery. So we're basically going to get him in a ketogenic state, put him on an anti-inflammatory response that way, and then eventually keep promoting autophagy and get his circadian rhythms normal so we can optimize his mitochondrial function. But specifically in phase 1, these are the things we're going to do. First, we're going to identify patterns that exceed frontal lobe metabolic rate by looking at symptoms of brain fatigue that include the following. And these are all specifically things that we picked up from the history specific to him. Inability to fall asleep due to fatigue of the frontal cortex, and inability to dampen the reticular activating system. So you have to remember that the frontal lobe activates the inhibitory pathways to the reticular activating system. That's how you actually fall asleep. But if his frontal lobe is totally fatigued, he can't activate the inhibitory pathways to the reticular activating system. So his mind is going on like crazy, the thoughts, and he just can't shut his mind off, so he can't get to sleep. So if he really fatigues his brain that day, he probably is not going to be able to fall asleep. So that's one issue. Irritability and mood changes during the day are also another indication his brain's fatiguing. He has a very unique response of skin sensitivity. When we think of skin sensitivity, you typically we think of like histamines and inflammatory responses, but skin sensitivity can also happen when the parietal lobe is close to threshold, and then all of a sudden the skin becomes really, really sensitive. There's also the possibility of what's called neurogenic inflammation that may cause that. Neurogenic inflammation is you get fatigue and the sympathetic system goes up, which we know it does with him because he's got dilated pupils and increased heart rate, and that actually turns on release of substance C, and then you get these catecholamines that depolarize nociceptors, and the substance P activation, and these catecholamines make pain fibers, including the skin, extremely sensitive. So that's the potential that may be happening there. He gets facial muscle tightness that he physically feels when his brain's fatigued, and then he has this very unique symptom that he noticed himself, which he refers to as brain shaking. It's really hard to determine what that is, but it's what happens when his brain's tired. So we want him to really identify these patterns. If he's having these patterns all day, he'll never get better. So we have to figure out how much load he has to stimulation to his brain, and then reduce it so it doesn't exceed it, so these symptoms go away. This is going to be the deal breaker. Number 2, perform a sleep study to consider a trial with CPAP to see if you can improve sleep, recovery, and improve brain function. Anytime a person doesn't feel better when they first wake up after several hours of sleep, you always have to consider that they may have nocturnal hypoxia, and this is where you want to get a sleep study, and maybe even just a trial with the CPAP to see what happens. Order a ketone meter and determine if the current diet is in ketosis. We want to see, as he eats, is he in ketosis? Once we know he's in ketosis, we want to have him use exogenous ketones and MCT, keep his ketone levels up throughout the day. And then he's going to experiment with how much ketones he needs to take throughout the day to keep those levels above 2. The higher the ketone levels, the more anti-inflammatory responses we get. So we want to keep his mitochondria healthy with lots of fuel and precursors so he doesn't fatigue throughout the day. And we can really promote that mitochondrial biogenesis pathway. Stop work at 6 p.m. and find strategies to take breaks throughout the regular workday to avoid brain fatigue. Continue with current nutraceutical supplements. There's really nothing else to add. He's taking all these, nutraceuticals that he found work for him. The last thing I want to do right now is mix and play with those. At this point, these are the key issues that we're dealing with, is getting his mitochondria more efficient, getting his circadian rhythms under control, promoting autophagy, mitophagy through long-term fasting. Those are what we want to do. There's no supplement I'm going to recommend to him that's going to be a game changer for him. He's already figured out what to take to dampen his neuroinflammation and support his brain and support his gut function and so forth. Establish a daily circadian rhythm that includes meal times, exercise, snacks, and sleep. We need to be precise with this. This is so important for promoting mitophagy and getting his mitochondrial efficiency to take place. And then I ask him to email an update weekly that includes symptoms of brain fatigue, the ones up here, sleep quality, the ability to maintain a circadian rhythm, and general observations and outcomes. That's what we want here. Then phase 2, once the ketogenic diet has taken place, progression to long-term fasting for 3 to 5 days to promote autophagy will be conducted. And then maintain ketosis and regular cycles of long-term fasting for 6 to 8 months. So ketosis, stopping brain fatigue, high amounts of ketones throughout the day with exogenous ketones, progress into fasting 3 to 5 periods, promote autophagy, mitophagy, clear that out, and then see what happens to his energy levels. And at 6 to 8 months, it's pretty realistic to start seeing some change. It's not going to happen overnight. I would expect him to have some symptom improvements the first couple months, but that would be optimistic. Prognosis is guarded. We don't know if this diagnosis is accurate. We don't know if this treatment plan is going to work. There's always some trial and error, the case that's complicated. So we'll have to see and make adjustments if things are not working out the way we need to. But that's the case wrap-up and treatment plan for Colin. Thank you.